Hi, this is Richard, your acting CNE, and welcome to my first in-service for B22. Now, I thought I would try something a bit different and try and record these in-services. Given that we are facing a lot of difficulties around time and the increasing workload with winter, it's just proven to be a bit difficult to find the dedicated time to deliver in-services. So I wanted to experiment with some different ways of delivering education for you all. So I will still try and to deliver these in-services in person, but this will serve as a backup system and it'll also allow staff who aren't present on the day an opportunity to access these sessions. So later on, I will discuss how staff can access these videos if you ever want to return to them, because who knows, maybe you really like the sound of my voice, but ultimately, hopefully, my goal is to make these in-services targeted to things that are relevant to you on the floor, and hopefully they can act as a resource that you can return to sort of solidify any messages that you might find helpful. So let me know if you like this approach or if you don't like this approach, much like the drug bell that I've implemented to try and find the SA keys. Georgia, I know you're not a fan, but thank you for being honest about that. I must say this is my fifth attempt at trying to record this, and I really don't like listening to the sound of my own voice, so I will push on and we will get into it. So, since I began in B22, there's been quite a number of Met calls, and I really do want to start off by emphasizing that I am very impressed by the teamwork and work culture that is here and present in B22, because my time in the casual pool going around this hospital, I can tell you when Met calls did occur on particular units, I was often left alone and I didn't see other people coming to aid and assist. But everyone, if they're able, they do come and help here in B22, and I just think that's an amazing thing that needs to be congratulated and praised. But I did pick this topic because just given the amount of Met calls that we do have, it might be worth just going over some points and tips that I've acquired over time. Not because I think anyone is doing anything wrong here, far from it, but I have had some people ask me some questions about aspects that have occurred during Met calls. So I thought it might be a good topic to go over and just hopefully share some of the stuff that I've learned in my time as I had my ALS training when I was at RPA and I was part of the arrest team there. And also in ICU and CCU here, I've been exposed to quite a number of Met calls as well. So hoping to share the knowledge that I've gained with all of you. In service, thought I'd start off with a quote that I actually have on my locker in CCU from one of my favorite philosophers, Seneca. What can happen at any time can happen today. Now, on the surface, that might sound a bit morbid, but I actually think this is a good mentality to have when we come into work. We work with a customer base that are unwell, and their conditions can change very rapidly and very quickly without any warning. So I think it's a good mentality to have, to be prepared for anything to go wrong at any time, and to understand the steps and processes that are needed to help address any issues that could occur at any time. And usually when you want to go on break or at the most inconvenient time, or often at handover, is when these events usually occur. Patient is key. Now, another lesson from someone unrelated to nursing. This is the NASA astronaut Chris Hadfield. You may have seen him through various social media things playing guitar in space. But this man, I just love this guy's story. So he's recounted the time when 400 kilometers above the Earth in his spacecraft, it started to fill with smoke. He became blind, but he didn't panic. He relied on his training, and he later explained, "We don't rise to the occasion, you fall back to the level of your training." When I read that, again, I just thought related back to what we do here in the hospital, and especially from my own experience when I had my very first Met call as a new grad at RPA. I walked into a room, a gentleman had a chest drain in after lung surgery. He had lost quite a lot of blood very quickly and he was white. And I still remember to this day, I actually panicked. I didn't know what to do. I felt like I forgot everything. And then all the training that I had, or the basic life, just seemed to leave my brain at that particular point, and I never forgot that. And I just remember thinking I need to learn what to do better and go over it, and over it, so I never felt like that ever again. So, how prepared are you? If your patient required a MET or an arrest call, would you know what to do? Do you feel confident in your knowledge of your basic life support training? Is your area prepared? Have you checked your suction? I already know the answer to that. Have you checked your emergency equipment as well? Is your area sort of clear of clutter? Again, very difficult in B22, I know, given the sort of constraints and the geography of our unit. Do you know your patient's resus status as well? I have a very sort of meticulous approach when I start my shift. I prepare all my notes. I look at everyone's resus status, their allergy, their infection, and I document all of that. I prep my notes as I'm getting handover a lot of the time. I've just seen it so often, and it's one of those things you don't want to happen to you where you are unsure of their resus status, and you don't want to be looking through your handover sheet when the Met team arrive, trying to figure that out, or trying to find a WOW that has like got no battery, or you have started CPR on someone who's established that they don't want that for them. It's just not a situation that feels great. So being prepared, I cannot emphasize enough that being prepared just will serve you so well. And look, 99% of the time, the way I prepare for my shift is completely unnecessary because nothing happens. But the way I approach my job, it's for that 1% of the time when I really do need it. So the more often you prep and you do it each day in each shift, it will serve you well moving forward, I believe. And I do think you have to look at it as an investment for your own development and for the care of your patients as well. So we'll just go over the clinical review system quickly because all of us, we should know this like the back of our hands by now. So we've got the yellow zones and the red zones. Patients who observations are hitting that yellow zone require a clinical review, meaning that the respective team should see the patient within half an hour, and any patient's observations reaching that red zone would require a more urgent review. So maybe if there are any students listening in the future to this, the system here in New South Wales Health, if you do need to call for a clinical review, you call 2222 and it'll take you through to the emergency phone who will ask you the reason for your call, where you're calling from, patient's details, MRN, and they will want to know the contact details for the relevant team. So the aim of SIRS is to improve early recognition and response to clinical deterioration and help reduce potential preventable deaths and serious adverse events. MEC calls. The red zone means we call a MEC call. I'm pretty sure every single time someone has knocked on my door or come to the office or found me asking if I could have a look at a patient for them to see what to do, it's pretty much always been a MEC call. I would like people just to start backing themselves in terms of their clinical decision making. If someone looks unwell and they're hitting the red zone, just call it. I will come and help you out if I'm on the floor. Hopefully, I am at the time. It's just one of those things. I don't want people to delay a decision because they feel unsure. They feel like they have to justify the reason for calling something for their patient. If someone is unwell and they're in that red zone, just do it. I'll come. I know how to restock that trolley really quick now, and then it will help get the ball rolling a bit quicker on the treatment for our patients. So keep calm, stay with them, call for the help by pressing that red button. If you need to, start CPR. Otherwise, we need to start thinking about the steps next for our patient and prepping our story. So, how do we hand over? I think we all know that we use ISBAR, introduction, situation, background, assessment, and recommendation. I do have to sort of emphasize this point though. When the Met team arrive, you need to get to the point. We need to tell the team when they arrive what was the reason that we needed to hit the red button. Was it low SATs? Was it low GCS? Are they unconscious? I mean, obviously, if we're doing CPR, they'll kind of figure it out. But we need to sort of like establish. They need to know straight away what was the reason, why have they been called, and then they will start asking you about their background. What was their reason for admission? What was their history? But when they initially arrive, we should be telling them, hello, My name's Richard. I've called the Met call today for Mr. So-and-so because the SATs were down to 75% on a background of COPD that they've come in with and other history. And yes, please help. So just burn this structure into your psyche, and the more you practice it, the better that you'll become at it. So there is that sort of awkward time between pressing the red button and then waiting for the Met team to arrive. So before we can do the handover, I probably should have moved this slide above ISBA. But anyway, we need to sort of default to our training, and BLS, basic life support, should be kicking in around this point. All of us train in basic life support, and this is the action that will keep your patient alive till the Met team arrive. Just the other day, there was a situation where a patient, their GCS dropped and their patient became unresponsive. And then later on, in a bit of a debrief, one of the staff members was just asking me they weren't sure if they should have commenced CPR or not. All I said to that was like, look, just start. Trust me. If they don't need it, they'll let you know. The patient will wake up pretty soon like, what are you doing? It's just one of those things where if the patient is unresponsive, CPR needs to be sort of commenced pretty urgently to help make sure that the cardiac output is maintained for the patient. So again, like anything in this entire in-service, I'll just be emphasizing, go over these systems till they're burnt into your brain, checking for danger, checking for response from the patient. If there's no response, we're sending for help by calling 2222, hitting that red button, and then going through our processes, our A, B, C, D, which I'll cover a bit more later in this presentation. Okay, so 2-3 minutes have passed since we've hit the red button, and finally, the amazing Met team have arrived. So I just wanted to go over who is actually on the Met team, because potentially maybe some of us aren't aware of how the team is structured. When they arrive, there'll be an ICU registrar. There'll be a nurse from ICU as well, or potentially even our Met CNC. They are our ALS, our Advanced Life Support Trained staff members. There'll be the on-call medical registrar, who will probably be in Building D and having to trudge all the way over to Building B, so it might take a while. There'll be a wards person if we need assistance with, I don't know, security issues or pushing the bed to X-ray or some other department. If this is a confirmed cardiac arrest, that also needs to be communicated through the 2222 system so that the cardiology registrar will arrive, and we may also need to get the Lucas as well, which we have here in B22 as well. If the patient is suspected of having a stroke, we will, again, when we call 2222, we'll be saying stroke code, but that is also a Met call as well. The Met team will arrive for a stroke code, and if they deem that their services aren't required, they will step down, but it does need to be put through as a Met call and a stroke code. And of course, you guys, you are part of the Met team as well in this situation. Okay, now we can talk about my best friend since I've been here in B22, the Met Trolley. I am pretty sure I have checked this Met Trolley at least 10,000 times. No, not really. So I'm actually thinking of giving the Met Trolley a name. I'm thinking of calling her Metsy. Very original. And I just thought it'd be worth going over some of the items that are in the trolley, because like anything, the more you check this, the better it'll stay in your mind where items are, because in the heat of a moment during an arrest, sometimes just logic seems to go out the window. We might be running to the med room when everything that you need might be in the trolley. So I just thought it'd be worth going over the items in the trolley just to sort of re-emphasize what is there and then our requirements for the trolley as well. So what's inside Metsy? Maybe I won't call her Metsy anymore. So what is inside the Met Trolley? We've got our 5 drawers, and I will say that when I first arrived here, drawer number 1 was atrocious. It was completely jam-packed with way too many items. There is a temptation, I think, when people are restocking that they have to put more items in there because they think that'll help. I actually find it's unhelpful because during an arrest, you want to be able to visually see quite easily where items are. So you may think that by putting in more pathology bags or more gauze or more syringes and cannulas, you're being helpful, but quite often I find that's not the case. So stick to the count that's on the checklist as well, because if you do believe, because that has been deliberately picked to help aid in an emergency. So in our first drawer, we've got all of our IVC access stuff and our blood taking items, our blood sugar machine, our neurotorch and scissors and things like that. Drawer number 2, which I haven't aligned very well in this display, but I wasn't going to do it again, is our drugs and our IV fluids. Drawer number 3 is all our airway equipment. Drawer number 4 has our sort of respiratory items and our nasogastric tubes, catheter tip syringe, and drawer number 5 is a bit of our miscellaneous items. We've got another bag valve mask down there, kidney dishes, and the tags as well. So the more you check this trolley, again, repeating myself, I know, but tough luck, the easier you will be able to locate the items during an arrest call. Anyone scribing? Probably the most common thing I've heard since I've been here at a Met call. I have a new rule. If anyone says, "Is anyone scribing?" you are now the scribe. How about that for an effect? See that transition? I do not even know how I did that. So what do you write during a Met call? Honestly, just start writing. You document what is happening. Oh, I really should have made this writing in black. I'll change this for later. If you are scribing on the WOW, you will use the F5 function to bring up the exact time and date. If you use this function as you continue during a Met call, it's just an easier way instead of actually manually writing the date and the time. And you will be documenting observations, medications administered. Ideally, you should be documenting about every 5 minutes, but that's not a hard and fast rule. It's just kind of something I've picked out of thin air. And, well, it might be in the policy. I really should read that. But if any major things are happening within that 5 minutes, you should be documented. So if someone has given adrenaline, if someone's given IV mag, if someone's put in a cannula, if someone has put on the pads, or anything that you think is relevant, you should be documenting during your scribing tasks. If we don't have a computer, then we actually do have these forms on the trolley in the white folder that sits on top of the trolley. I don't actually like the way these forms are structured, but hey, it's not up to me. It's just no one ever seems to use that area to stick on the DFib printouts. So if I do have to write this, I don't bother worrying about that section. I just keep writing all the way across the page. But, as long as you're writing something, that's better than nothing. Okay, roles. The best arrest calls, and when I say best, the ones that have been the most effective and run well, are the ones where people assume roles quite quickly and they communicate well. The communication should be via the team leader. They should be the loudest voice there. And if a team leader directs something to be given, if you are on drugs, I would recommend calling out the order again so that you can confirm what they said and the scribe can hear it. And if you're the scribe, you should be repeating out the message as well when you document to prevent any discrepancy. So just for an example, if the team leader says, "I would like to give 1 milligram of adrenaline," if you're on drugs, you would be saying, "Yep, drawing up 1 milligram of IV adrenaline, administering adrenaline now," and the scribe, "Okay, documenting adrenaline given." So if we need to go back to see when the last dose was given, hopefully that's all been communicated well and our scribe has documented the time that it's been given to. So we have our team leader. We should be someone manning the defib machine, which we will go over soon. If we've got CPR, that'll be someone doing that. And hopefully if there is someone doing CPR, we have enough people potentially to take over, because it is quite a tiring thing doing CPR. Someone should be someone should be just preparing the drugs if that is required during this event. You may need someone else just to find items in the trolley, and we have our scribe, and then other people who might be support and runners, and probably if we are running out of stock, we will need someone to go to the storeroom to get more syringes, needles, things of that nature. Coached. Here we go. So, coached. I'm going to read this very dry description that I took from the Liverpool ALS self-directed learning package. Coached is a defibrillation sequence used in advanced life support during rhythm analysis to ensure defibrillation, safety, and minimal interruptions to chest compressions. The way I look at it, coached is essentially designed to bring order to chaos. ALS staff are taught to memorize this system. It's not an acronym that easily rolls off the tongue at first. Ward nurses aren't really expected to be fluent in this algorithm. However, it is good to be aware of it, because if the patient is requiring CPR and then later defibrillation, you may hear these things yelled out. So C, I'll go through it all. C is continue compressions. Oxygen away is O. I'll keep going through it. All others away, charging, hands off, evaluate rhythm, and we're, depending on what the rhythm tells us, we either defibrillate or we dump the charge, meaning we get rid of it, and then we repeat this process until we have a good outcome. If we get to D, we wait 2 minutes and we go again. And this is the pathway that is used during advanced life support as well. So if we've begun CPR and we've attached the defibrillator and then moving down when we're assessing the rhythm, depending on what the rhythm tells us will dictate the pathway that we go as well. So if our patient is in a shockable rhythm, which is VF and VT, basically all the squiggly lines, and we deliver a shock and they haven't come back, we continue CPR for another 2 minutes. If there's a non-shockable rhythm, meaning a PEA or asystole, we continue CPR and go again after 2 minutes. On the side, on the right of this flow chart, you'll see on drugs, if the patient is in a shockable rhythm, we would give adrenaline after the second shock. If it's a non-shockable, we would give adrenaline after the first shock, after the first round, and then amiodarone would be required if we've made it all the way up to 3 shocks and we haven't brought the patient back. If the arrest is going for quite a while, then there would be things to consider that may have caused this event. And that in the ALS training they go over is remembering your 4 H's and your 4 T's. So the reasons that may have caused this, is this event related to hypoxia, hypothermia, high or low electrolytes like hyperkalemia, hypokalemia, hypothermia, and then moving on to the T's, is this related to a tension pneumothorax, a tamponade, toxins, or a thrombus? So while we're waiting for the Met Call team to arrive, there are things that we can sort of prep in anticipation of them arriving. We should be getting our handover ready with our story about what's occurred. Do we have good access to the room? Does the patient have IV access as well, in case we need to give fluids or other medications? Drawing the curtains around if the patient's in a 4-bedded bed space, let's draw the curtains around the other 3 beds. They don't need to see what's going on. Removing any family members, which can be difficult in some instances, but we really do need to remove them so we can do our job. And if they want to stay close by, that's fine, but they shouldn't be at the bed space interfering in what is already a pretty tight area to work with. Someone should find a wow that's working, because eventually someone's going to ask about the medications the patient's had or their recent blood results. We can do an ECG if time allows, and if the situation allows for it as well, do a blood sugar, and attending our observations regularly. So if the Met trolley has arrived, the DFib has the capacity to do the observations and check the stats as well. So I would advise using that to do our observations, just to try and remove the clutter around the bed space, as the observation machines can be quite bulky and just get in the way. So during the Met call, how should we be behaving, or how should it be structured really? we should be following the leader. There should be one captain. We don't need lots of voices dictating what's going on. So if the ICU register is there, or if the med reg is there at the time, we need to establish who is in charge, and that's the person that is leading this treatment for this situation. We all need to keep calm. It is a high stress environment and event, but that doesn't mean we have to be rude to each other. Protect the patient's airway, and then talk to your patient if they are awake, if this is a situation where they haven't fallen unconscious, as maybe their condition will change. And during the events of a met call, while everything is happening, if they suddenly have a drop in GCS, we need to know as well. Now, let's talk about something that's a little bit more scary, intubation. If we need to intubate and you are called on to assist, just be honest. Always tell the doctor who is in charge of intubating the patient that you may not be experienced in this field and you might require their guidance. There might be a situation where maybe there's multiple met calls going on, someone has arrived and this patient needs to be tubed and you're the only nurse there. So I'm not saying that will happen, but there is a possibility. I have seen it when I was during my time in another hospital. And it's just a situation where you have to be honest with it. Look, I've never done this. If you guide me, we'll go through it. But hopefully someone does arrive who's ALS trained, because we don't actually keep all the equipment in our met trolley to help facilitate an intubation. So the role of the assisting with airway nurse should be someone who's completed their sort of airway training and ALS training as well. That will most likely be the ICU staff member of the Met team, but that doesn't mean that you can't assist and at least help out and find some items for them to help make the whole process easier too. We'll talk about the defib a bit now. So this is probably the closest picture I could find to our defib that we keep on our Met trolley. There is a few little differences, but I just wanted to go over how to set up the auto and non-invasive blood pressure measurements. So when the screen has been turned on, when we're turning that black dial towards the red side, defib, just as a quick point of, just for a quick note, we actually don't have that green section there where it says pace on our defib, but I don't want to go too much into that. But essentially, if you need to do blood pressures for your patients, where that red circle is when we turn on the display screen, there'll be the word parameter. We press that, then there will be an NIBP display on there. Press that, then settings, and then auto interval. So for those who are unfamiliar with how to get to that point, and if you want to learn, please come find me. You know, the arrest trolley sits outside my office there. We can go through it. It really doesn't take that long. And it's one of those things I would rather you practice in the calm environment instead of trying to do this in a time when everyone's adrenaline's really going. For other skills that we can practice, so how to set up the defib, like I was just discussing as well. If you are unfamiliar with how to do it, please, 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 I will show you. I really, really do not mind if you want to get more familiar with that. How to place pads as well. I mean, I've got the mannequin sitting there in my office. I'm sure he has a name. Someone has told me, but we can go over how to put the pads on accurately as well. Priming a rapid infuser. If you've never had to prime a rapid infuser before, again, I don't mind wasting a bag of saline and a line. We can practice that as well, because it's one of those things, if you get it wrong and you get air in there, it's very time consuming. You may as well just get another line and start again. Knowing the items in the trolley. You really should make yourselves familiar with the Met trolley. Given how many Met calls that we have had, it's not a bad practice to either volunteer or just, if you want to crack it open and recheck the Met trolley, go for it, because I really do think people should know that thing by like the back of their hand. Scribing as well, just if you are unfamiliar with how to scribe, if there's a Met call and I'm there and you want to give it a go, let's do it. And then also how to implant the simple airway devices like the Goodell and the nasopharyngeal ones we can practice in my office at any time. So just quickly going over some of that basic life support details. A is for airway. So every single nurse, including myself, will write when they're doing their A to J assessment, airway, patent. So let's keep it that way during this situation. When you're doing your basic life support training, you will be assessed on how to do your head tilt, chin lift, or jaw thrust if they've had like a spinal injury. If there is an obstruction, obviously we don't go digging around with our fingers to get it out. We're using the suction. If the patient is unresponsive and has no cough or gag reflex, that's when we would be thinking about using the Goodell's. Now we are up to B for breathing. Now, did you know when you assess for breathing, when you look, listen, and feel, your brain will actually get Wi-Fi powers? It's the only reason I picked this image, just to do that joke, and I'm sure it wasn't that good. Now, we are looking for the equal rise and fall of the chest when we're assessing these patients. If we don't see that and we don't feel any breath, then unfortunately it's time to move on to C. So C, circulation or compressions. Why have I used an image of a dog? That's a good question. Well, we are coming up to 30 minutes now, and I know people's brains are usually switching off by now, so I essentially use this just to shock you and wake you up a bit. We can go over the correct technique of how to do compressions on the actual mannequin. It's hard to talk about it too much in this sort of medium, but essentially you want to be placing your hands in the center of the chest. The compression should go a third of the depth of the way down. Our ratio is 100 per minute of a ratio of 30 compressions to 2 breaths. I think most people should know that the adage of how fast should I be doing, there's that sort of song that you can use to sort of keep the rhythm of the uh, uh, staying alive. And I cannot believe I just sang on this. Hope that doesn't come back to haunt me. And D is for defibrillation. So just running through these points, when we turn the defib on and we've correctly turned on the pads, we should make sure that the pads are actually connected to the defib when we're checking the Met trolleys. If we need to give a shock, that will be directed by the ALS staff manning the defib, and they should ensure that all staff are clear by loudly stating "stand clear" and ensure, and exactly in that English tone as well, and ensure that everyone is safe, and that we are not touching, because if you are touching the bed when we deliver a shock, you'll be going flying across the bed space, and then we'll have 2 Met calls to deal with. The aftermath. At some point, the Met call will end, and if our patient has been stabilized, then the process should be that we will be performing an A to G assessment on them, making sure everything is, we got a baseline now of what to be mindful of moving forward. We should commence our post-Met call observations. Because of the nature of what's just happened, these patients will still need close observation, so we should be doing hourly obs on them for the next 4 hours. Potentially they might need transfer to another unit if they require more monitoring or something a bit more invasive, or an infusion that we shouldn't be administering here in B222. So you might be needing to prep the patient, getting their meds, getting their notes, getting their belongings, and transferring them off to either ICU or CCU or wherever they need to go. Before the Met team step down as well, if the patient is staying here on the unit, we need to discuss and establish the post-Met call plan. What infusions need to be done? Do we need to alter any calling criteria? Do we need to update their resus status? If the family are around, we should be updating them as well. And by we, I mean get the doctors to do that part. If it's been a particularly stressful event, then we need to organize a debrief and reflect on what has happened. From my own experience in these situations, again, I mentioned before about how I was a new grad and I had a situation where the patient had a big dump of blood. He was fine. I should have emphasized that before. He ended up going to ICU, but overall he had a good outcome. Reflecting on our own processes as well. Is there stuff that we should be aware of for next time? Is there lessons that we can take away? Is there something that we wish we knew before that? And if we need to learn something moving forward, how do we go about that? Again, that's where I'm here to help assist with that in that regard. I don't think it's a bad thing to admit when we need help or assistance to help improve our treatment and our outcomes and our practice as well. But if it's also been quite a traumatic event, there's also other options available. There's the EAP system here in the hospital that people can reach out to if they need counseling. But hopefully that doesn't occur to anyone here. But if it does, there are avenues to explore for that. And I just want to end on a final message with two quotes from books that I've read that sort of re-emphasize the message I think I've peppered through this entire presentation about repeating the boring things, going over your processes, and why that is so essential in what we do. So the first quote from the book Atomic Habits, you do not rise to the level of your goals, you fall to the level of your systems. So what does that mean? Mastery is the result of consistently executing small, often boring habits over time. And the other quote from the book Peak by Anders Ericsson, quote, the reason that most people don't possess these extraordinary skills isn't because they don't have the capacity, it's because they aren't willing to go through the necessary period of deliberate practice. So, which means deliberate practice, which is focused, repeated, effortful, is what builds expertise. And yes, it is often boring. So why am I going over this? So really what I'm trying to say is the level of confidence and sort of that I have when it comes to this situation isn't because I have some natural gift to be good at this. It's because I force myself to be exposed to these things and I've practiced. When I did my ALS training, look, I know this sounds crazy, but every day when I walked into the hospital at RPA, there was a certain point I knew after I passed this doorway, it would take this long to get to the ward. I would go over that coached algorithm every single day because I was prepping myself for something in case I needed it. Because if you think about when you tie your shoes, you don't think about the actual process of it anymore because you do it so often. So for us here in B22, what I'm literally talking about is doing those things that you find quite boring, but they will help you out in the long term if we have an event here in the unit. So checking your emergency equipment, checking your resus of your patient, going over your BLS when it's due, and just trying to refine the skills that you think maybe you need improvement in, or if something has occurred, like, oh, okay, next time I need to improve in this aspect, we can go over that together. Again, I'm going to repeat the message I started near the top of this presentation 36 minutes ago now, that I really do think everyone in B22 has a really great work ethic, and there's such a good culture here about trying to assist each other, trying to help out, but that doesn't mean we can't find areas to improve as well. So I hope that we can all work together to try and sort of build each other up, because it's sort of a self-perpetuating thing where if one person can improve another person's skills, then that has a knock-on effect, and then we'll see a better outcome for all of our patients. So I hope this was helpful in some small way, and I've maybe moved the gauge in terms of your level of understanding in some way. So if you found this sort of delivery method good, let me know. If you get any feedback, look, I'm a big boy, I can take it. This is the first time I've done this, so over time, hopefully I refine the process and find it a bit ways to improve myself. Obviously, doing it this way is a bit unique, and I don't think I've ever encountered anyone doing this here. So let's hope this is something that can be done moving forward. And if there's something you would like to explore as well, reach out to me and I can show you the process of how it is. It really wasn't that difficult at all. And hopefully we can do more of these in the future. Okay, until next time, thank you very much.